The next topic on high-risk mother is on complications of labor and delivery. These complications occur during the period of labor and delivery, so please review again the 4 stages of labor starting from true uterine contractions until the first 4 to 6 hours after birth. Premature or preterm labor is true labor that occurs before the end of week 37 age of gestation. So again, you have to review ano yung characteristics ng true labor para ma-determine mo kung yun ba premature or preterm labor na. Plus, of course, you have to compute well kung kailan ba talaga ang kanyang due date. Based on how you computed, no, una, based on the LMP, yung kanyang expected date of delivery. Pangalawa, pwede ring ma-determine through ultrasound. Premature or preterm labor is threatening to the fetus because of immaturity. The organs may be formed, no? Formed well na yung mga organs intrauterine life. Pero it is still immature para kayanin o mag-function siya sa extrauterine life. Why labor begins before a fetus is mature is unclear in most instances, but it may be associated with, number 1, cervical incompetence. As we mentioned before, bumubukas yung cervix, nagdadilate yung cervix nang hindi pa naman oras. It could be because of preeclampsia or eclampsia also. Dahil sa preeclampsia or eclampsia, nagkakaroon ng vasospasm. And that actually stimulates the inflammation din, no, or uterine contractions. Maternal injury, dehydration and infection, lahat ng yan pwedeng mag-cause ng inflammatory reaction which stimulates uterine contraction also. Multiple birth and too much weight gain. Normally, one body can carry only one baby. Kaya ang multiple birth, by virtue of knowing the uterine stretch theory, when an organ is full, it will empty. Kaya pag mas mabilis na pupuno yung uterus, mas mabilis siyang nag-empty. And placental disorders, fatigue or stress, incorrect lifestyle. Lahat ng yan, nagkakaroon ng stimulation sa myometrium to contract. Some of these are modifiable and some are non-modifiable causes. And of course, yung mga modifiable, we should prevent those para nang sa gayon ma-prevent din yung premature or preterm labor. Warning signs of preterm labor must be taught to a mother. Unang-una, dapat alam niya kung kailan ba yung kanyang kabuanan. At kung hindi pa naman oras ng kanyang panganganak, tas naramdaman niya itong mga to, kailangan agad niyang magpa-refer. First, no, abdominal pain, it is not normal. Ang expected natin sa babaeng malapit ng manganak is shortness of breath. But abdominal pain is something that is not usual. Contractions, which are actually regular, increasing yung duration, intensity, frequency, which are characteristics of true contractions and not false contractions or false labor. Pelvic pressure, nagumpisa sa balakang. Vaginal discharge that is heavy, baka mamaya amniotic fluid na yon, nag-rupture yung membrane. Low dull backache, menstrual-like cramps, yun pala talagang nagko-contract na yung uterus, and bleeding and spotting, baka meron ng bleeding discharge, nagkaroon na siya ng bloody show. The other warning signs, so again, yung backache or pelvic pressure nga, edema of the hands and the face, which means na meron siyang preeclampsia. No? Posibleng may preeclampsia siya at isa yun sa risk factor ng preterm labor. Again, regular contractions, which is true contractions already, nausea, vomiting, diarrhea, or other flu-like symptoms na hindi naman niya nararamdaman before. Eye or visual disturbances, again, abdominal pain or cramps, reduction in fetal movements, which means the Fetus might be experiencing fetal distress already, leaking fluid from vagina kasi nag-rupture na yung membranes, and the mother just feels worried and concerned. The mother just don't feel right. So pag ganon, paparefer din siya. Now, a woman with the following may be at a higher risk of preterm labor, lalo na yung mga nagsusmoke, they use substances such as alcohol or drugs, those that are carrying more than one baby. As mentioned earlier, those with poor nutrition, underweight before pregnancy, tas dati nang nagkaroon ng preterm deliveries, or those with infection. Now, kung ang babae ay may high risk from preterm labor, it can be detected, and that is through fetal fibronectin. Kinukuha ito via vaginal mucus. Fetal fibronectin is a protein from the trophoblast, and it indicates that preterm contractions are ready to occur. At kapag ganon, as early as possible, you have to stop it and prevent labor. Kasi may mga pagkakataon na hindi na kayang i-help or i-stop yung labor. Remember that when the problem is a preterm or premature labor, the goal is to stop it because threatening siya sa fetus. And if you detect it early through fetal fibronectin taken via the vaginal mucus, mas mape-prevent siya at magiging successful. To prevent premature or preterm labor, again, yung mga high risk, nagsismoke, taking substances, early and consistent prenatal care according to EINC, if everything is normal, healthy, both mommy and baby, 4 prenatal checkups are okay. Appropriate diet and weight gain, normally 25 to 35 pounds. Pero, depende kung yung mother may cardiovascular condition. As mentioned before, no, kailangan yung weight gain kapag may sakit sa puso, nililimit lang, usually 15 pounds. Minimize stress, prevent infection, and kailangan alam ni mommy yung signs ng premature labor. The goal, again, is to stop labor ASAP. However, kailangan alam natin kung ano ba yung criteria kung kailan lang pwedeng i-stop ang labor. Medical attempts to stop labor can only be made if the following are present. Una, membranes are intact. Hindi pa nagra-rupture. Pangalawa, walang fetal distress. Pangatlo, walang bleeding si mommy. Pang-apat, the cervix is not dilated more than 4 or 5 cm and above. At pang-lima, the cervix is not effaced more than 50%. Kung yung limang yun, nandoon pa, medical attempt to stop labor must start right away. What is the management now to stop labor? First is keep client at rest, probably on a side-lying position. This will relieve pressure of fetus on the cervix para hindi tuluyang bubuka ang cervix kung bumuka na siya ng kaunti or hindi totally magbuka. Second is hydrate the patient. Kasi pag ang patient dehydrated, posibleng ma-activate ang posterior pituitary gland, which will then secrete antidiuretic hormone na magkukos ng release of oxytocin na lalong magpapastimulate ng labor contractions. Third is to monitor mother and baby. Siyempre, yung vital signs, i-check. I-check din minsan yung mga vaginal or cervical cultures or urinalysis. Baka may infection or UTI. Baka kailangan mag-start ng antibiotics or even prophylactic antibiotics. And of course, these are the medications. Magnesium sulfate, it's a known drug for preeclampsia, anticonvulsant. Dahil nervous system drug siya, maaari siyang mag-control ng uterine contractions, but it is not used anymore right now for premature preterm labor. Next is terbutaline or ritodrine. It's a beta-2 agonist as a tocolytic. no? Nagsa-stop siya mismo ng labor contractions. There is less hypertension and tachycardia as a side effect here. Nifedipine is a calcium channel blocker. Calcium stimulates muscles to contract. So pag na-block siya, no, calcium channel blocker, nape-prevent ang muscle contraction ng myometrium sa uterus. Indomethacin is a prostaglandin inhibitor. And prostaglandin stimulate uterine contraction also. Isoxazoline is a vasodilator. Again, mape-prevent ang uterine contractions. What now if there is a risk of the labor na hindi na siya ma-stop or ma-halt? As an emergency situation, as an emergency intervention, you can give dexamethasone. Latest EINC protocol is to give dexamethasone 6 mg IMQ 12 times 4 doses. Kaya dapat, ang sabi ng EINC, lahat ng labor and delivery room may nakaprepare na ready DEXA. The photo shows an ampule of DEXA na ang preparation ay 4 mg per ml. So, D over H times Q, 6 mg divided by 4 mg times 1 ml, which means you are to give 1.5 ml for every injection of DEXA to the mother. What is the reason why we give DEXA to the mother? It crosses the placenta. And when it crosses the placenta, these corticosteroids accelerate formation of lung surfactant. Very beneficial siya sa fetus kasi kapag nag-improve yung lung surfactant niya at ilabas siya kahit premature, kahit papaano, nagkakaroon ng lower rates ng respiratory distress syndrome and bronchopulmonary dysplasia or other respiratory problems. Kasi yun ang pinaka-concern, lalo na kapag premature si baby, yung lung surfactant niya is immature. Now, it takes about 24 hours for dexamethasone to have an effect once na binigay mo siya sa mother. Kaya, importante na sana yung labor ma-halt that long para mag-pass through pa siya ng placenta at maibigay kay fetus para magkaroon ng acceleration ng formation ng surfactant. Also, in the Philippines, DEXA is usually used, pero pwede rin ang betamethasone. In other countries, binibigay ang betamethasone. Also, the effect of DEXA lasts for 7 days. So, if a newborn is not born, naging successful yung initially na pag-halt ng labor, so hindi lumabas yung baby, huminto ang contractions, yung effect ng DEXA, especially when it comes to lung surfactant, is only 7 days. Kaya pwedeng iulit or the dose may be repeated in the next 7 days kung meron pa rin risk ng premature labor. Now, discharge teaching. So, napauwi na yung mommy, nag-stop na yung labor. Teach mother to monitor fetal movements kasi ito'y tutulong para sa pag-monitor kay baby no fetal distress. Normal average, 10 to 12 movements in an hour. I mentioned also that when you are to halt labor, may criteria dapat. But in what case is there a point of no return? Meaning, ito yung point of no return in stopping or delaying labor. Kaya ito, lumabas na yung baby ng premature. Una, pag pumutok na yung panubigan. Pangalawa, yung dilation nga niya, halos nasa 45 cm and above na. And yung effacement, at least 50% efface. It's a point of no return, ilabas na si baby kasi mas lalong tataas naman yung risk of infection. Now, yung immature fetus, possibly ilalabas yan via CS. Or, kung vaginal delivery naman, may need episiotomy. The question is, premature yan, preterm yan, maliit baby, no, ideally. Pero bakit kailangang CS or kailangan pang i-episiotomy? Maliit nga siya usually. It's because we want to prevent head compression during labor. This can cause subdural or intraventricular hemorrhage kasi nga very delicate yung brain tissues ni baby at baka magkaroon ng pressure sa ulo, magkaroon pa ng problem sa brain and the nervous system. Aside from that, yung preterm umbilical cord may need to be clamped immediately. Ang sabi natin sa EINC, yung cord pulsations should be stopped, no? Kailangan hintayin mo nang huminto yung cord pulsations bago siya i-clamp in 1 or 3 minutes. Pero pag preterm ang baby, clamp immediately because an immature infant may have difficulty excreting bilirubin. At dahil dito, dadami yung indirect bilirubin niya, baka mamaya magkaroon pa ng kernicterus and the rest will follow. Another complication of labor and delivery, ito naman ay yung postmature or prolonged pregnancy na opposite ng premature or preterm labor. Here, walang nagaganap na labor, halos matatapos na yung kanyang kabuwanan. And remember that this is of utmost priority also. Ang goal dito, kabaliktaran nung preterm birth or preterm labor. Sa preterm labor, the goal is to stop labor. Dito naman, ang goal, kailangan mailabas na yung baby. Okay, why? Because the placenta is effectively timed to last for 40 to 42 weeks lang. May expiration date kasi ang placenta. At after those weeks, no, pag nakalagpas na yung expiration date ng placenta at hindi pa lumalabas yung baby, kawawa naman si baby. Magkakaroon siya ng poor perfusion. It can even cause meconium aspiration syndrome due to fetal distress. Magkakaroon ng pag-expulsion ng meconium ni baby sa loob ng uterus. Malulunok niya yung meconium, and we mentioned sa normal pregnancy, hindi dapat niya malunok ang meconium kasi paglabas ng baby na yon, may nakabara doon sa kanyang airway at may hirapan siyang huminga. Tapos meconium pa yon. It's a waste product. It's a waste product, so baka magkakaroon pa siya ng infection or pneumonia. Now, sino yung mga at risk for postmature or prolonged pregnancy? Sometimes sila yung mga babae na meron ding long menstrual cycles around 40 to 45 days. Pangalawa, those who took high doses of salicylates because it can interfere with prostaglandin synthesis. And again, prostaglandins initiate uterine contraction. Pangatlo, yung may mga myometrial quiescence or deep freeze, para bang hindi gumagana yung myometrial muscles nila. Now, sabi nga natin, the goal is to get the baby out, no? Because yung mga complications kay baby, for example, na-mention ko nga yung meconium aspiration syndrome, it can really lead to severe sepsis and even pneumonia in newborns. And it's one of the leading causes of neonatal death. The goal here, of course, is to ascertain the precise fetal gestational age and condition. Dahil kailangan alam ng nanay kung kailan ang kabuwanan niya. At hindi na dapat niyang hihintayin na lalagpas doon, hindi pa siya nanganganak. That's why the mother should know. And of course, pangalawang aalamin mo yung fetal ability to tolerate labor. Kasi at this time, kakayanin pa ba niya ang labor? Kasi kung hindi niya kakayanin yung labor, kasi nga halos expired na yung placenta, baka kailangan niyang cesarean section. So those are the things that we have to ascertain. You think the baby would look old sa isang postmature or prolonged pregnancy? Yes. This is a sign of desquamation. Nagbabakbak na yung balat, nawawala na yung moist ng skin. Remember, the placenta is a very good moisturizer. Kaya nga, lahat ng baby ang gaganda ng balat. Pero pag na-expire na yung placenta, nawawala rin yung ability niya to moisten or moisturize the skin. Kaya nagkakaroon ng desquamation, and remember dun sa Ballard scoring system, yung desquamation, it's a sign of um, post-maturity in a newborn. In post-mature or prolonged pregnancy, the goal is to immediately deliver the baby. Some tests can be given, no? First is yung vaginal fibronectin test to determine again the presence of fibronectin, as mentioned earlier, non-stress test, and biophysical profile. So please review the non-stress test and biophysical profile. Obviously, magiging abnormal ang result niya kung post-mature or prolonged pregnancy na dahil doon sa risk ng fetal distress. If the results of the test are normal, ibig sabihin lang nun, the due date is miscalculated. So, kailangan i-recheck ulit. If abnormal, therefore, post-mature or prolonged pregnancy is really diagnosed, important to deliver the baby. First is to induce labor. You have to monitor closely the fetal heart rate for placental insufficiency. Paano mag-induce ng labor? Maaaring magbigay ng prostaglandin gel o kaya misoprostol inilalagay sa cervix. This initiates a ripening of the cervix and the stripping of membrane followed by oxytocin infusion so as to stimulate uterine contractions. If this is unsuccessful, cesarean section is indicated. Let me discuss here the concept of dystocia. When you say dystocia, it's a general term for any difficulty of labor. Now, the frequently seen causes are cephalopelvic disproportion, hindi kasya yung ulo ni baby sa pelvic bone ni mommy because of two possible reasons. Una, malaki masyado yung baby pero normal naman yung size ng pelvic bone, or maliit yung size ng pelvic bone kahit normal yung size ng baby. Problems with presentation, lalo na ang transverse position, and problems with maternal soft tissue. For example, merong tumor o kaya may mga myoma that may interfere with normal labor process. And lastly, dysfunctional uterine contractions. We mentioned before that uterine contractions should reach its peak, no? Yung duration niya dapat at least 60 to 90 seconds. Yung frequency niya every 3 to 4 minutes, or contractions should be at least 3 to 4 in 10 minutes para maging effective yung pushing and ma-deliver si baby. Pero may mga cases na non-functional or dysfunctional yung contractions, which is actually a form also of difficulty labor. Prolapsed umbilical cord is the next complication, and this is the displacement of the cord in a downward direction near or ahead of the presenting part or into the vagina. If you look at the photo, kitang-kita naman na nauuna yung umbilical cord kesa kay baby. So, naiipit niya yung umbilical cord pababa. It may occur because membranes have ruptured or with ensuing contractions. Remember that all throughout the pregnancy, maaaring healthy at normal ang lahat, pero all of a sudden, prolapsed umbilical cord happen or prolapsed umbilical cord happened during labor and delivery. Assessment findings, maaaring makita yung presenting part doon mismo sa vaginal opening or cervical opening or within the uterus through ultrasound. Now, in this case, we have to check right away the fetus. Because remember that when labor happens with prolapsed umbilical cord, naiipit ni baby yung umbilical cord. And yung umbilical cord, yung passageway ng lahat ng dinadala ng placenta to the baby. Kaya pag naipit niya yan, magkakaroon ng compression ng umbilical cord. And again, recall the deceleration during labor, variable decelerations may occur. Ang goal natin dito is initially i-relieve ang pressure sa cord. This is usually associated with breech presentations. From the photo, you will see na kapag breech yung presentation ni baby, mas malapit yung pusod from the vaginal opening. Kesa kung cephalic presentation, mas malayo yung pusod from the vaginal opening. Also, unengaged presentations. There are instances wherein engagement does not occur, lalo na sa mga succeeding pregnancies ng isang mommy. And when there is no engagement, hindi naka-anchor yung fetal head from the ischial spine of the pelvic bone. Kaya posibleng merong spaces from the sides na pwedeng malusutan ng umbilical cord. Ganon din ang premature labor because the baby is possibly small, and with a small baby, wala ring engagement, no? Magkakaroon din ng extra spaces from the sides para malusutan ng umbilical cord. Definitely, prolapsed umbilical cord is an obstetric emergency, especially if there is too much compression of the cord. Again, ito yung passageway ng oxygen, lalong-lalo na from the placenta to the baby. Kaya pag na-compress ito ni baby during labor, fetal hypoxia may result. And yung fetal hypoxia na yon can cause further damage to the baby, such as CNS damage or even death. We mentioned that in prolapsed umbilical cord, nauunang lumulusot si umbilical cord. But in the photo, is this correct? Push back the umbilical cord in. This is not correct. You do not do that. And what are the important interventions kapag may prolapsed umbilical cord? First, i-check ang fetal heart rate agad and report decelerations. Anong klaseng deceleration? Ang posible nating makita dito, yung variable deceleration. Second, what you need to do is, yung goal nga kasi natin, mawala yung pressure sa cord. So para mawala yung pressure sa cord, you have to exert an upward pressure against the presenting part to lift part of the cord. Meaning, hindi yung pusod ang itutulak mo, kundi yung presenting part ni baby na umiipit dun sa cord. So, from the sides of the mother's vagina, yun yung pwedeng i-exert ng upward pressure, but not the actual cord. And then, unti-unti, get help to move the mother in a position wherein gravity will assist sa pagtanggal ng pressure of the cord. One possible position is the knee chest, as what we can see in the photo, or severe Trendelenburgs. So, dun sa photo, nakikita natin, yung pusod nandoon pa rin naman. Wala kang tinulak, hindi mo siya itutulak yung mismong pusod. Ang itutulak mo, yung baby, doon sa step number 2 in this slide. And then, unti-unti, by gravity, no, yung position ni mommy, kasi ang goal natin dito, priority goal, remove the pressure from the cord para walang variable deceleration. So, looking at the photo, hindi na naiipit ngayon ni baby yung umbilical cord niya. Then, you can administer oxygen, prepare for immediate cesarean birth. This baby cannot be delivered vaginally. Dahil pag tinuloy ang labor, maiipit niya ng tuluyan yung cord all throughout the labor, wala siyang maayos na blood supply habang nandoon pa siya sa loob ng uterus all throughout the labor. And that is very dangerous to the baby. Kaya cesarean section. So habang piniprepare yung CS, ang goal, again, habang ganito na naghihintay ng cesarean section operation, relieve pressure of the cord. What do you now do with a protruding cord? Let it be, no? If cord protrudes outside vagina, huwag siyang gagalawin, takpan lang ng sterile gauze moistened with sterile saline just to prevent infection. And lastly, no, na-notify mo na yung physician para prepare na yung cesarean section. In premature rupture of membranes, pumutok ng maaga yung panubigan. There are two forms actually. One is just PROM and the other is PPROM. Yung PROM, premature rupture of membrane, pumutok ng maaga yung panubigan pero full term si baby. Yung PPROM, preterm premature rupture of membrane. Maaga na ngang pumutok yung panubigan, preterm pa si baby. So, the PROM thought alone, yung sinasabi nating maagang pumutok ang panubigan, ano ba yung sinasabi nating maaga? Because from the normal labor and delivery, if you recall, no, ang pagputok ng panubigan ay dapat nangyayari sa active stage of labor, right after bloody show. At sa active stage ng first stage of labor, ilang cm dilated. Ang dilation, kapag active phase of the first stage of labor is about 4 to 7 cm dilated or 4 to 8 cm dilated. May mga libro magsasabi 4 to 9 cm dilated. No? Pero, active phase, dapat may paghilab na rin ng tiyan. At dapat nagkaroon na ng bloody show. Pero minsan, ang bloody show, di ba, hindi na-appreciate kasi sabay. Yung pagputok ng panubigan, sa pag-rupture ng operculum, hindi na-appreciate yung dugo ng nag-rupture na capillaries kasi mas marami yung amniotic fluid na lumabas. But anyway, yun, no? Ibig sabihin, pumutok na maaga yung panubigan, hindi pa active phase yung stage. So, maaaring nasa latent stage pa lang or halos wala pa, no? Yung nagaganap talaga na true labor contractions. Now, this is usually associated with chorioamnionitis or infection of the membranes. Ang concern natin kapag nagkaroon ng maagang pagputok ng panubigan ay yung mga komplikasyon. Unang komplikasyon, yung maternal and fetal infection. Kasi nga, ang agang pumutok ng panubigan. So, mas matagal na nakabukas yung cervical opening, maternal infection, lalo na sa uterus ni mommy, endometrium, and fetal infection or neonatal sepsis. Second is prolapsed umbilical cord, which was discussed earlier. Sa prolapsed umbilical cord, dahil maagang pumutok yung panubigan, by gravity, bababa siya. So, baka pati si umbilical cord, by gravity, bumababa din siya. Another is oligohydramnios. Kasi, mas mabilis na uubos yung amniotic fluid. Pero, remember, there is never a dry labor kapag nagkaroon na ng premature rupture of membrane kasi pumutok pa lang naman yung amnion. Pero hindi siya nawala. The amnion still produces amniotic fluid. With premature rupture of membrane, similar to preterm labor, no, yung mga usual interventions natin, dapat, syempre, ilalabas mo na si baby, no, as early as possible because you want to prevent all its associated complications. Pwedeng magbigay ng prophylactic antibiotics. Pwede ring magbigay ng amniotransfusion, no? Lalo na kung yung baby ay merong oligohydramnios at that time or a fibrin-based membrane sealant. via endoscopic uterine procedure. Ito naman, kung si baby ay preterm, meaning we wanna halt the labor, sobrang preterm niya. Yun nga lang, this would involve, of course, other possible complications. Kaya tinitignan din natin ilan ba yung kanyang age of gestation. Tapos aalamin din natin kung preterm ba, PPROM, confirmed, or there is no um, prematurity. So again, in premature labor, of course, you cannot halt the labor anymore. So ilalabas mo si baby and do necessary interventions to prevent all of the other possible complications. Consider also kung yung baby nga ay at si fetus mismo no ay premature mismo or kulang siya sa buwan, less than 37 weeks. If this complication happens similar to other complications, what can occur to the fetus in general? That is fetal distress. And at the same time, meconium aspiration syndrome can happen too. We will further discuss the meconium aspiration syndrome when we deal with neonatal disorders. But again, the principle is basta't nagkaroon ng any kind of fetal distress sa loob ng uterus ni mommy, yung rectal sphincter magre-relax. At pag nag-relax yon, lalabas ang meconium and kasama yung sa amniotic fluid na normally nalulunok ng fetus intrauterine life. And the danger there is when the fetus is born, nakabara sa airway niya yung thick meconium. The newborn's alveoli is designed to absorb the thin amniotic fluid. Malabnaw lang siya. Pero pag may meconium, malapot, hindi nakadesign ang alveoli doon na maabsorb. Kaya pwedeng magkaroon ng respiratory distress and aside from that, infections such as pneumonia. Next is precipitous labor and delivery. It is labor less than 3 hours. It's actually an emergency delivery without the client's physician or midwife. So ano yung makikita mo dito? As labor is progressing quickly, rapid assessment should be done. Client may also have a history of previous precipitous labor and delivery. Yung desire to push very early. Kasi normally, yung desire to push kapag nandun na sa transition phase of labor at halos gaano katagal na siyang nagle-labor noon. Almost more than 10 hours, no? Or checking the normal span no, nung latent, active, and transition phases. Matagal siya. And of course, observe status of membranes, perineal area for bulging, and for signs of bleeding. Kung iisipin mo, parang okay naman ang precipitous labor and delivery. Parang hindi na nahirapan si mommy kasi ang bilis niyang manganak. Pero, the threat here is on the mother. Kasi, ideally, yung cervix, ang bilis niyang dito, ang bilis mag-dilate at mag-efface ng cervix. Ideally, hindi dapat ganon. No? Dahil sa normal labor and delivery, the cervix usually in the active phase, 1 cm per hour. Ganon siya dapat kabagal. The cervix is a fragile tissue. At kung ganon kabilis yung pagbukas no, at pagnipis niya sa precipitous labor and delivery, baka magkaroon ng mga cervical lacerations, cervical tears, or baka sa mga susunod na pagbubuntis ni mommy, magkaroon naman siya ng premature cervical dilatation. It's a forceful, rapid contraction. Minsan, ang cause niya, nagkaroon ng abruptio placenta kasi, o kaya nagkaroon ng fetal subdural or intraventricular hemorrhage, no? I mean, yung causes, so delikado kay baby, nabanggit ko nga kanina, yung cervical lacerations, plus ma-overwhelm yung mommy. Okay, sa isang primipara, 5 cm per hour yung precipitous labor and delivery. So, ang laki. Sa mga multipara naman, no, minsan 10 cm per hour yung ganun kabilis yung precipitous labor and delivery nila, which is very critical to the mother and also to the baby. Management is simple. Ayan na yung crowning na. So, syempre, wala kang gagawin, support the infant's head and assist with delivery of the infant. Hindi naman natin pwedeng ipasok yung lumalabas na baby. So, ang kailangan nating tignan right after the birth, kumusta si mommy at kumusta si baby. And then, provide immediate care. The last of all the labor and delivery complications ay ang pinakadelikado sa lahat, and that is amniotic fluid embolism. It's the escape of amniotic fluid into the maternal circulation. It's usually in conjunction with a pattern of hypertonic, intense uterine contractions, whether natural or oxytocin-induced. In the photo, you will see the green arrows. Yung green arrows, yun yung amniotic fluid na lumabas. Because ideally, nandun lang dapat sa loob ng uterus yung amniotic fluid. But because of hypertonic, intense uterine contractions, suddenly lumabas siya via the maternal circulation. At kapag napunta siya sa blood vessels, of course, magkakaroon ng clotting because in the blood vessel, blood lang na dapat ang nandun. The presence of amniotic fluid in the blood vessel will trigger clotting. Hence, magkakaroon ng emboli. So, delikado kay mommy, lalo na pag nakadating sa emboli, no, yung clot, naapektuhan na yung cardiorespiratory circulation. It's both an obstetric emergency and may be fatal to both the mother and the baby. There are several risk factors. Advanced maternal age, multiparity, meconium, or any signs of fetal distress, nagkaroon ng cervical laceration, nagkaroon ng intrauterine fetal death na hindi agad na ilabas, very strong yung uterine contractions, sudden fetal expulsion, or ito yung tinatawag na precipitous labor and delivery, nagkaroon ng placenta accreta. When you say placenta accreta, yung placenta beyond the endometrium nag-attach, which is hanggang myometrium pa siya. Merong iba pang ganyang klase, umaabot pa ng perimetrium and beyond. And we know that only the endometrium is capable of shedding off. So, delikado ang placenta accreta. Polyhydramnios, uterine rupture, may history ng allergy, si mommy, chorioamnionitis or infection, macrosomia, having a fetus na male, and the use of oxytocin also. There are several risk factors, but nevertheless, these and other frequently cited risk factors are not consistently observed, and at the present time, experts agree that this condition, amniotic fluid embolism, is not preventable. Threatening siya to the mother most especially because of the emboli in the circulatory system. That's why all of the body systems are affected. Kasi all of the body systems nagkakaroon ng problems doon sa blood flow going to them. General, yung tingling sensation, numbness, lightheadedness, chest pain, vomiting, and cough. And then, sa respiratory, nahirapan ng huminga, bronchospasm, pulmonary edema, and acute respiratory distress. Cardiovascular, babagsak ang BP, and then biglang tataas, cyanosis, chest pain, and delikado pag nag-arrest. CNS could develop seizures, headaches, and changes in the level of consciousness. Hematology, so yung clotting itself, tas nagkakaroon ng DIC, as we have discussed or mentioned previously. And si fetus, no, pinakadelikado kay fetus, syempre, nagkakaroon siya ng bradycardia. So, yung fetal heart rate niya bumabagsak. Now, clinical presentation, there's a sudden drop in the oxygen saturation. This can be an initial indication ng amniotic fluid embolism, lalo na pag may cesarean section. More than half of patients die within the first hour, so very poor ang prognosis. Of the survivors, half of them will develop DIC. So nagkakaroon ng maliliit clot along the blood vessels, and DIC leads to hemorrhage. This may manifest as bleeding from incision or venipuncture sites. Sa DIC, makakakita kayo ng mga oozing blood from previous injection sites na dati kang in-inject sa location na yan, ngayon may makikita kang oozing blood. That's DIC. And yung coagulopathy typically occurs 30 minutes to 4 hours after phase 1 or the initial escape of amniotic fluid from the uterus. So this paradigm explains to us what happens as the amniotic fluid enters the maternal bloodstream. So obviously, its presence, the presence of amniotic fluid in the maternal blood vessel will cause emboli, clotting. Obviously, pag may clot, magkakaroon ng obstruction and yung mga vasospasm, magsikip. Kaya magkakaroon ng multi-system condition and will lead to death. Kung magsusurvive naman, because of the lack of oxygen supply to several body parts, nagkakaroon din ng mga impairment. Nursing interventions initiate emergency life support activities for the mother. Obviously, this mother would be needing artificial life support. Nag-i-insert ng endotracheal tube or an ET. As you can see in the photo, may ini-insert na endotracheal tube. When you say endotracheal, endo via mouth, trachea hanggang trachea. That tube is where the big machine, which is the mechanical ventilator or respirator, is attached. At yung machine na yon ang nagpo-provide ng artificial oxygen going down the respiratory tract. As nurses, it's very important that you always maintain the patency of that tracheostomy tube or the endotrach. Paano natin laging sinisiguro na tama yung placement ng endotracheal tube? Well, first, because it provides oxygen, dapat when you auscultate the breath sounds, clear ang breath sounds, right and left. Dapat equal and clear kasi yung pinoprovide na oxygen ng machine dapat pantay nakakarating sa kanan at kaliwang lung fields. Kung gamit ka ng stethoscope, pinakinggan mo yung right lung field, okay, may clear breath sounds. Nung nilagay mo siya dun sa left side ng lung field, wala ka nang marinig. Baka mamaya hindi na in place yung endotracheal tube. Baka mamaya nandoon na lang siya nakasettle doon sa right side ng lung. Okay, second, because the endotracheal tube passes through the trachea, and the trachea is known as the voice box. Dapat walang boses yung patient. If the patient is conscious and the patient initiates to speak, wala dapat siyang boses. So it's one way of checking that it is in place. Tama na nakalagpas siya ng trachea. Kaya kapag may mga naririnig na mga mini voices of a person with tracheostomy or a respiratory tube that passes through the larynx, dapat walang boses. Third, you will see the ventilator or the respirator na nagra-rise and fall. Obviously, yung rise and fall na yon ng ventilator machine equals the rise and fall of the chest. Yung rise is the inhale, yung fall is the exhale. So si machine dapat pantay sa movement ng chest, or the rise and fall of the machine should equal the rise and fall of your patient's chest. Kung hindi sumasabay yung rise and fall ni machine dun sa chest, well, ibig sabihin baka hindi rin intact yung endotracheal tube. And last is the most accurate one, which is doing the x-ray. Kasi from the x-ray, doon mo makikita talaga that the ET is intact, patent, at nandoon siya sa trachea. Pero hindi ka pwedeng mag-x-ray every hour, every 8 hours, no? So, ibig sabihin, you can make use of other assessment findings to always make sure that your ET is in place. This is a very important nursing responsibility when caring for a mother with AFE. Kasi definitely this mother is in an ICU. And ICU, critical care, ang kailangan sa kanya, kaya yung monitoring, syempre, lalo na ang placement ng ET is very important kasi ito yung kanyang artificial airway for now. Second is to establish IV line for blood transfusion and monitoring ng central venous pressure if necessary. Ito yung pag-measure ng mismong pressure ng ito yung pag-monitor ng mismong pressure ng chambers of the heart. Okay? Administer medications to control bleeding. Please review pharmacology. What are the drugs to control bleeding? These are the thrombolytics, no, to remove or dissolve the clots, and then anticoagulants or antiplatelets to prevent further clots. Prepare for emergency birth of the baby because obviously the mother is compromised, so baka si baby ay maapektuhan din. And lastly, keep the client and family informed as possible. So that's it for the complications of labor and delivery. Please review again, no? Remember to review the normal labor and delivery concepts for you to be able to explain the reason for the abnormalities. That's it. The end. Thank you very much.